Hi, so in this video I'll be talking about the different types of calcium channel blockers, clinical use, toxicities, all those things. So first of all though, I want to talk about the different types of calcium channel blockers. Now really, calcium channel blockers can be divided into two broad categories. One is dihydropyridine and the other is non-dihydropyridine. These are the two broad categories, dihydropyridines and non-dihydropyridines. Now, under the umbrella of non-dihydropyridines, there is again a couple of other divisions of calcium channel blockers, and they are phenylalkylamine calcium channel blockers, so phenylalkylamine calcium channel blockers, and benzodiazepine calcium channel blockers, and non-selective calcium channel blockers. So these are the three broad categories under the non-dihydropyridine. Now before we jump the gun, let's talk about dihydropyridines first. How do we know that a calcium channel blocker is going to be a dihydropyridine? Anything that's going to end in a dine is going to be our dihydropyridine. Okay. Now, this particular group of calcium channel blockers are responsible for controlling systemic vascular resistance. Okay. So we have our heart here, and we have our different arterioles here. Okay. So these dihydropyridines are more effective in the systemic vascular resistance than the heart. Okay, it's going to be more effective in the systemic vascular resistance than the heart, and that's why we use dihydropyridines to treat systemic vascular resistance. Okay, so we use to treat systemic vascular resistance. Now these dihydropyridine calcium channel blockers, do we use to treat angina? Do we use to treat angina? Not dihydropyridines. We do not use dihydropyridines to treat angina. Okay, why we do not use dihydropyridines to treat angina? That's because when these dihydropyridines is going to work on these vessels, what's going to happen? These vessels are going to become larger, right? Because it's reducing the resistance and making the vessel kind of expand. This creates hypotension, and this hypotension is going to affect the heart, and it's going to cause reflex tachycardia. Okay, that's why if someone has angina and you're using this for both hypotension, both systemic vascular resistance and angina, this is going to make your angina worse, because this is going to cause reflex tachycardia because of the hypotension that is being created all over the body. That's why we do not use dihydropyridines to treat angina. But there are some exceptions. Okay, and I try to remember the exceptions using the mnemonic AN. A-N-N. A for amlodipine, N for nicardipine, and the next N is for nifedipine. These are the three exceptions where we do use it for angina, and they are dihydropyridines. Why and how? I don't know. I don't think we have to know at this point why these are the exceptions, but these are the dihydropyridines which we use for angina, but in general we do not use dihydropyridines to treat angina. Okay, so enough about dihydropyridine. Let's move on to the next category. The next we have phenylalkylamine calcium channel blockers, which falls under the non-dihydropyridine. Now, whenever we're talking about the phenylalkylamine calcium channel blockers, we're specifically talking about Verapamil. Now, before I talk about the non-dihydropyridine calcium channel blockers, I quickly want to talk about the action potential of a pacemaker cell and action potential of a ventricular cell. So what is an action potential of a pacemaker cell? Okay, it kind of looks like this, right? If you have trouble understanding action potential, please feel free to visit those videos that I have made. So this is of a ventricular cell. Now we know that this is phase 0, this is phase 4, and this is phase 3. In this case, this is phase 0, 1, 2, 3, and 4. Okay, so let's talk about them very, very briefly. What happens at phase 0? At phase 0, we have opening most of the sodium and the potassium funny channels. Okay, funny channels open for sodium and potassium. There is also opening of some calcium channels. Okay, and there is closing of the regular potassium channels. That happens in phase 4. What happens in phase 0? At phase 0, we have opening of the voltage gated T-type calcium channels open, right? And that's why we have the depolarization, the big depolarization is generated by the T-type calcium channels at phase 0 of the pacemaker cell. Now, I would just want to mention that the end part of the slowly depolarizing action potential before it hits the threshold, that those calcium channels are L-type. Okay. And so that is phase 4, phase 0, and phase 3 is obviously opening of the potassium channels, which is causing repolarization because a lot of the potassium is coming in, making the cell more negative. Okay, so what I want you to understand, or what I want you to remember, is that where do we really see the calcium here? The big, fast depolarization of calcium is happening here. So if we use calcium channel blockers in the heart, it's probably going to be most effective at this phase, at phase 0, right? We already know that, but this is just revision. Now let's talk about the ventricular cell really quickly. This phase, is 0 phase, is mostly sodium coming in. This is mostly potassium. This is mostly calcium opening. This is potassium, and that's potassium. So if we use a calcium channel blocker, where do you think is going to be most effective? It's going to be most effective at phase 2. So phase 2 in the ventricular cell, phase 0 on the pacemaker cells, if we did use calcium channel blockers. Okay, so let's go back to our non-dihydropyridines. And we were talking about phenyl, alkylamine, calcium channel blocker, verapamil being the example. So what's interesting about this calcium channel blocker is that these calcium channel blockers, they are selective for the myocardium. Okay, so now since we know that this is selective for myocardium, if we did use it in the myocardium, it's going to act on those phases, right? On pacemaker cells, it's going to act on phase 0. On ventricular cells, it's going to act on phase 2, right? Because that's where the calcium channel is. Okay, so these are selective for myocardium. Another thing we have to know about phenylalkylamine calcium channel blockers is that they reduce myocardial oxygen demand, okay, and they reverse coronary vasospasm. I just cleared out a little bit space here because it was getting a little messy. So anyways, so I wrote down here that verapamil, it reduces myocardial oxygen demand and reverse coronary vasospasm. So don't you think that since it reduces myocardial oxygen demand and it reverses coronary vasospasm, this is our ideal candidate for treating angina? Okay, that's why we use verapamil to treat angina. Okay, the non-dihydropyridine, which is a phenylalkylamine calcium channel blocker, used to treat angina. Okay. What else do we know about verapamil? Okay, another interesting thing about verapamil is that it is a calcium channel blocker. Okay, it blocks the calcium channel. So what happens with all the calcium? The calcium gets trapped inside the cells. Just like it gets trapped inside the pacemaker cells, it also gets trapped inside the ventricular cells. And what happens when there's trapped calcium in the cells, in the ventricular cells? The cell is more prone to contraction. As a result, prolonged use of verapamil is going to cause ventricular fibrillation and death. That is also something very, very important that we have to know, that prolonged use of verapamil, I'm going to write this here. So, prolonged use of verapamil will cause atrial fib and death. Okay, very, very important. So that's why understanding the differences between dihydropyridines and non-dihydropyridines, specifically phenylalkylamine, is so important. So the next category is benzo calcium channel blockers. Now, by having both cardiac depressant, which is a benzo, and a vasodilator action of the calcium channel blocker, they both reduces arterial pressure, okay, without producing some degree of reflex cardiac stimulation. So when we use benzo, benzo is a depressant, it's a cardiac depressant. Calcium channel blocker, it's a vasodilator. Together, this is going to cause systemic vasodilation without causing a reflex tachycardia, right? Without causing reflex cardiac stimulation. Now, this is going to be under the benzo calcium channel blockers. Now, what is an example of a benzo calcium channel blockers? An example is diltiazem. Again, diltiazem is a non-dihydropyridine calcium channel blockers. Okay, last but not the least is non-selective calcium channel blockers. Okay, so for non-selective calcium channel blockers, we have examples like Phenyl. Okay, more commonly we use Bepredil. Okay, so these drugs are going to fall under the non-selective calcium channel blockers. So we have to know that Bepredil, it is also an anti-anginal drug. Okay, because typically we know that non-dihydropyridines are better for angina. We've seen verapamil being our best choice. Diltiazem is also not really bad because we have benzo and calcium channel blocker together, but it does have some systemic effect. If we want something very, very cardioselective, we have to go for verapamil. And non-selective, so it works everywhere. Bepredil is also, being a non-selective, it is also used as an anti-anginal drug, anti-hypertensive drug, because this is, non-selective, which gives us the option of treating anti-anginal and anti-hypertensive drugs. Okay, so let's wrap this up. Just a general point that I want to mention is that the non-dihydropyridines, specifically phenylalkylamine, such as verapamil and beta blockers, never ever together. Why? Tell me why verapamil and beta blockers should never be prescribed together. The reason for that is because verapamil, it is very, very cardioselective. It has effect on the pacemaker cells. It's going to depress our pacemaker cells. Beta blockers does exactly the same things. It also has a major effect on our pacemaker cells. So if we have double pacemaker cell depression, then that will probably kill us. So that's why we never use verapamil and beta blockers together. So that is a major no-no. So that is my interpretation of calcium channel blockers. I know there's a lot more information, but I kind of ran out of time, but I think I pointed out the major points here. Other things are a lot more obvious, so I think It's okay not to mention it in this video, but if you want me to make another video to encompass everything else we have to know, please leave me a comment below. I will be happy to do that. But these are some of the points that I wanted to mention, very, very important and very, very high yield for step 1.